It's such a pleasure to be here with you all today, and I'm so thankful I was asked to be a co-presenter for such a wonderful program. So just a couple more acknowledgments, although Krista did a great job of giving an overview that this program is supported by a grant from the Administration for Community Living. So we've been delivering this behavioral interventions program for about the past 2+ years in the greater Toledo area. And it's been a huge success for offering it to many different audiences, and we're so lucky that we're able to expand this to you all today. We'd also like to acknowledge the state of Minnesota Act on Alzheimer's. They were generously shared to us some of their training curriculum, and we're able to adapt this presentation from some of those materials. So just acknowledgement to them as well. And then we can move to the next slide. So just a quick overview of the learning objectives for today. So we're going to be identifying different causes of dementia, understanding the importance of timely detection and effective tools to identify dementia, recognize common behaviors among people who are living with dementia. We're going to be learning some different methods for analyzing behaviors for people who are living with dementia, as well as determining some root causes of challenging behaviors, as well as in applying interventions to reduce behavioral symptoms. And we're going to be looking at implementing some systematic non-pharmacological approaches to manage behavior symptoms. And then at the end, we're going to be providing you with a list of some online resources and books and a program as well to help support individuals who are living with dementia and their caregivers as well. And we'll move to the next slide. So to start today, we're actually going to be looking at a few case studies throughout today's program. But to start, I'm going to read this one to you, and then through the program, we're going to be looking at a few more. And as we move along through the program, we're going to be looking at some tools, so that way we can actually get some input from you all as far as what tools might be effective, and use some of these learning objectives to address some of these case scenarios. So just to start, I'm just going to read this, and you can follow along. So Jane Smith is 76 years old. She lives in the home of her daughter and the daughter's husband. The daughter and husband have 3 adult children who are living out of the house. The daughter has come to you with concerns that Jane is quick to take offense at almost any suggestion from the daughter. Jane resists taking showers, claiming she does not need a shower that day. There have been occasions when Jane has gone almost 2 weeks without bathing. Furthermore, when making suggestions to Jane, the mother often responds with belittling things about the daughter. You are fat. You are stupid. Never did have good sense. The daughter says she would like to keep her mother at home with her, but says she doesn't know how much longer she can go on in her caregiving role. And just some additional information is that the daughter says that she's been told that Jane has dementia, but she doesn't know if it's Alzheimer's disease or another cause of dementia. She also knows that her mother takes a pill and a patch for Alzheimer's, as well as something for her blood pressure and sleep. So again, just to give you an idea of kind of why we're talking about this topic today, and that these are often common occurrences, and we'll continue with looking at some other case studies as well. And we can move to the next slide.
So are you able to hear me okay? I'll do one sound check here. Okay, great. I'm Marty Williman, and like Lindy said, it's just great to be with all of you here today. We're going to start out with just this basic overview of dementia, including some of the very common signs and symptoms of different types of dementia. So we can move to the next one. Just a quick review of those signs and symptoms. We all know that memory loss, but sometimes our family members, the general community, do not know that it's the short-term memory loss that we're talking about in dementia. Long-term memories stay intact well into the disease. So it is that short-term memory loss. Then we have confusion, and you can just keep scrolling here. Confusion, disorientation, getting lost in familiar locations, changes in speech and language. And as we focus on changes in communication, that's what behavior is all about, right? That if I have dementia and I cannot find the words to tell you that I'm in pain, that I'm hungry, that I need to use the bathroom, I will show you in other ways what I need. And sometimes, frequently, those get labeled as behaviors. But behavior is just truly a form of communication for those individuals who don't have the language skills because of their dementia. So we also see trouble with timing and sequencing. When we look at that story about the woman who hadn't bathed in 2 weeks, surely not being able to keep track of time. With my experiences in home health care, this was the number one reason we had in home health aid go into the home, is because of the bathing issue. And 9 times out of 10, we'd show up at the house and the woman or the man would say, "You don't need to help me with my bath, I just took one yesterday." That was a very common scenario that we saw for those living with dementia. Certainly poor judgment and problem solving difficulties. We can keep advancing here. Changes in sleep and appetite, mood, personality, and behavior changes are also common symptoms. Changes in the ability to care for yourself, difficulty with those familiar tasks like operating your coffee maker, operating the washing machine, getting dressed as things progress. Finally, we all need to understand that these abilities fluctuate. And I'm talking about fluctuation from literally minute to minute, hour to hour, day to day. And this can be confusing for caregivers to understand that, boy, why was he able to do that yesterday and now today he has no idea? Well, it's the nature of the disease that those abilities are going to fluctuate. And a lot of times it's significant. And then just diminished insight, that lack of abstract thinking, being able to think, what should I do next? What might happen if I do this? That lack of insight really is a large symptom of dementia. So we'll move on to the next slide. We'll start, again, we want to just go over that basic definition, that dementia is a decline in mental functioning to the point where it's interfering with those daily activities and those social relationships. And this is another sometimes point of confusion in our society. People don't always understand, if I forget to pick up that loaf of bread when I go grocery shopping, is that dementia? Well, if it's happening every once in a while and it's not interfering with daily activities, forgetting to pick up a loaf of bread at the grocery store is much different than having a loaf of bread at home and not knowing what to do with it, what its use is. So there's real differences between common symptoms of dementia and normal aging. So we can go to the next slide. When we look at different causes of dementia, there are many. Actually, there are over 80 different kinds of dementia. This next slide will show you some of the more common types. Certainly, Alzheimer's disease is the most common one. It makes up about 60 to 80% of all dementia. But you see mixed dementia. People live with vascular disease and Alzheimer's, or they may live with Lewy body disease and vascular dementia. So we actually think a lot of individuals living with dementia live with mixed dementia. You can see frontal temporal lobe degeneration. We used to refer to this as Pick's disease. That's one of the more common types of dementia. And then on the right-hand side of that umbrella, those are some of the, outside of Alzheimer's disease, as I mentioned, that's the most common type. But Huntington's, Parkinson's disease, Creutzfeldt-Jakob disease, alcohol-related dementia, they're not as common, and also late is one of the newer identified types of dementia. The limbic predominant that you see there, that you see listed there. But these are just some of the more common types of dementia. And as we talk about some of the behaviors, it's helpful to know exactly what kind of dementia, if we have that knowledge in the chart. It's helpful to know what kind of dementia that person is living with. For example, with Lewy body dementia, that seems to cause more visual and auditory hallucinations. So we might see more behaviors related to that. With frontal temporal lobe degeneration, that affects mood personality, judgment, decision making. And so sometimes we will see behaviors related more to inhibition and perhaps more aggressive behaviors. So it really is important if we can find out the specific type of dementia. That said, it's estimated that only 40% of people who have dementia receive an official diagnosis. So this is a very underdiagnosed disease process. And those who do receive a diagnosis of dementia, a lot of times we don't have the ability, or we don't drill down into the specific type of dementia. So the more information we have about the specific type, I think the better we can manage and respond to some of the behaviors. So we'll go on to the next slide, and Lindy's going to give us just an overview of why that timely detection is important.
Yeah, thanks, Marty. So I think that, a lot of folks might, question why would a timely detection be important? We know there's not necessarily a cure for Alzheimer's or dementia currently, but there are a lot of really great factors that go into why it can be beneficial for families to seek out a detection of the dementia. There's some obvious reasons kind of listed there. I mentioned, families, that it will be helpful to involve the individual who's experiencing the memory loss or has the diagnosis of dementia to be involved with what they want to see in their care plan. And that will decrease some of the burden of the family when they know the wishes of their loved ones and kind of promote kind of independence moving forward. Another one is the removing, a barrier to a good compliance with other healthcare conditions. So you see a lot of older adults that have a lot of comorbid conditions. So for them to be able to get this, a diagnosis of dementia will help remove the barriers, such as, maybe an individual who is trying to manage their diabetes, but it's becoming more difficult to, manage the diabetes with the insulin, and it could cause a lot of unnecessary, maybe visits to the emergency room or other healthcare utilization with not getting a timely detection. So, and we'll move on to the next slide. So there are, I think hundreds of cognitive assessment tools that are available, and the ones listed are all available online. They, range from different lengths to, their accuracy and things like that to detect dementia. It's also noted that you always want to, seek out or consult a physician when, you might be looking at some of these assessments online. I was just going to point out a couple that it may be interesting assessment tools that are out there. One of them being the SAGE, which is the self-administered neurocognitive exam, which you can actually just do, on a pen and piece of paper, and then maybe you would take that into the individual would take that into the physician and see, consult with them what their findings were. There's also another tool that you might find interesting, the NPD, Early Detection Screen for Dementia. That's specifically used for individuals who have intellectual and developmental disabilities. So there's a screening tool for those individuals as well. So again, just sharing this list with you and knowing that these are available. And we'll move to the next slide. So for today's presentation, we're going to talk a lot about non-pharmacological interventions and psychosocial interventions, and we're going to put a lot less emphasis on medication. We're going to be looking at a lot of looking at the environment and some person-to-person, analyzing and methods for looking at behaviors and seeing that can be a really effective tool to kind of move away from medication if possible and look at other types of interventions. It's also noted that it's really encouraged for individuals or professionals who are working with individuals who are experiencing memory loss or have a diagnosis that they, you connect them or connect with community resources and build your support circle to the best of your ability, because that can be so helpful for caregivers and individuals to increase their support, and to be sure to refer at any stage, so early stage or middle stage or late stage. You can never go wrong with connecting with a community organization that can help decrease some stress and maybe some isolation or loneliness for caregivers and individuals as well. And we'll move on to the next slide. So another slide that just talks a little bit about why it's so important that we're talking about this topic today, and that being that these behavioral symptoms that we're going to kind of go into more detail about and identify some of these common behaviors, but is that they are, nearly all individuals are going to experience mood or behavioral symptoms during the course of their illness, and that up to 80% of nursing home residents have them. So we know that this topic can be very challenging and uncomfortable for caregivers. Is to try to find ways to help their loved ones who are experiencing a lot of distress, maybe too, from these behavioral symptoms. And we'll move on to the next slide.
Okay, thanks, Lindy. I'm Jennifer Wolf. I'm glad to be here with you today as well. And picking up where they've kind of led us so far, I'm so glad Marty mentioned earlier that behavior is communication, and it's really important for us to define some behaviors, and that can give us some clues as to what's going on with an individual. So we'll get into behaviors here. If you can go to the next slide. We know it's important to address behaviors because they can have some negative outcomes and some possibly dangerous outcomes for individuals. So we want to identify and then address these behaviors. Sometimes behaviors put people at risk. For example, wandering could lead a person to be exposed to the elements if they were, outside in winter or in the heat during the summer. Sometimes we see complications due to falls or increased mortality when individuals are on different kinds of psychotropic medications and maybe the behaviors are not being taken into consideration. So on the screen here, we have a few potential behaviors that could have negative outcomes as well. The quality of life, hospital stays being longer, increased system-wide cost, and we know that dementia has a high cost for care. Caregiver distress, and we're here to support caregivers as well. And we want to make sure that, if we have behaviors under control, that it will decrease the amount of caregiver burden, as well as premature nursing home placement. So we'll go on to the next slide, please. So on this screen, you see some common dementia-related behaviors, and some of them are pretty self-explanatory, but I also wanted to draw your attention to the socially inappropriate behaviors. Sometimes we see that in dementia, and that refers to things that might be okay in private, but not in public, like disrobing or masturbation. And so sometimes that disinhibition is something that we need to address with behavioral interventions. We also may see behaviors as acting out in some way, an action taking place. That could be like a person who starts repeating questions or resisting care. But sometimes we also see a change in behavior. So instead of a brand new behavior, maybe it's a change from what they previously had been like. So perhaps someone was very pleasant and happy, and now you're seeing them as very withdrawn or apathetic. So that would be a behavioral clue. Or the absence or reversal of a behavior could also be an indicator. So it may be a person who was had a pattern of yelling out in the past, and now they're not doing that. So it can be a brand new behavior, a reversal, or just a change in behavior. So we'll go on to the next slide. So we have our second case study here that I'll read to you, and then we'll kind of use this as we discuss behaviors further. So Tom Baker is 51 years old. He works part-time at the local grocery store and shares a group home with 4 other males ranging in ages of 40 to 50 years old who also live with Down syndrome. Tom's father is 89 years old and serves as Tom's primary source of support, including guardianship, and he lives in his own home in the same town as Tom. One adult sibling also lives nearby, while 2 other adult siblings reside in neighboring states. The father comes to you with concerns of Tom's recent weight loss, refusal to talk and participate in usual activities, and he states that Tom is crying a lot. He tells you that Tom can't seem to remember how to do simple things around the house anymore, and on one recent occasion, he struck out at the group home manager. He's worried that if this continues much longer, Tom will not be able to remain in the group home that he's always loved. Father states he's concerned about his own health conditions and the added care responsibility this will likely place on his other 3 children. More information, Father says that a year ago, a doctor told him that Tom most likely has Alzheimer's. This was about the same time that his wife, Tom's mother, was diagnosed with cancer. Sadly, she died 1 month ago. Tom takes daily prescription medication for his thyroid and arthritis, and occasionally takes over-the-counter medications for heartburn and constipation. So we're going to kind of use Tom's case here as we talk about behaviors, and we'll go to the next slide. So when we look at behaviors, we want to consider whether the behaviors that we see are really a problem. Is some of what Tom's doing a problem? Is it hurting anyone, him or someone else? Who is it bothering and causing a problem for? And later on, when we kind of break down things, we use the IDEA kind of process to identify behavior and explore the causes, adjust our what can be done and accept. So we're going to kind of use that as we look at Tom's situation here. So we want to recognize that, you know, perhaps for Tom, he's had some weight loss. He's not talking and participating in usual activities and crying a lot. So that's, you know, problematic. Who's that problematic for? Well, probably Tom, but it could be caregivers and family that's seeing him in distress. He doesn't seem to be able to remember how to do simple things. And he did strike out at the group home manager. So is that a problem? Is that likely to happen again? These are the kinds of things that we want to consider. Recognizing that some behaviors are common. So when we do that, we'll avoid having unrealistic expectations. And we can advise to take a deep breath and slow down, step back, simplify and smile, redirecting an individual, reassuring, and maybe trying again later can all be ways to address behaviors. Okay, we'll go to the next slide. So some causes of behaviors or challenging behaviors. Great. So we've got 3 categories of causes. One is physical health, and we always want to rule out any organic causes. For example, some medical conditions could cause some behavioral changes. We know that urinary tract infections are well known for causing mental health symptoms. So we would want to make sure that that was eliminated as a possibility or addressed if it was, in fact, a problem that the individual was having. Other challenging behaviors could be environmental. So having an unfamiliar surrounding could cause a challenging behavior. Being overly or under stimulated. So the sensory needs of the individual and whether the environment is just too chaotic or maybe it's kind of boring. These could be things to consider that could cause challenging behaviors. As well as other, so communication, and we're going to talk more about communication, having those unrealistic expectations. So maybe if we don't know what are commonly seen as dementia signs and symptoms, we might have unrealistic expectations for individuals that we work with or care for. Unmet needs and boredom, kind of that understimulation, but if there's a need that's not being met, it's going to be expressed one way or another, whether that's verbally or through behavior. Sometimes task-related frustration. So if the person is frustrated because they're not able to do something for themselves or do something that they want to do, that may come out as a challenging behavior. And then emotional health. You know, when we read through Tom's case study, he's having recent changes in refusal to talk and participation and crying a lot, but he also just lost his mother about a month ago after about a year-long battle with cancer. So is Tom getting the emotional support? Has he been able to process and grieve that loss? As you know, perhaps his verbal skills are less than maybe typical. So how are we addressing and supporting Tom through that emotionally? So these are three different categories, but we may see causes, you know, coexisting. So someone could have physical health challenges that are addressing their behaviors, but they may also environmentally or emotionally need some support. So these are just some things to consider as we kind of get curious about what is causing these behaviors we may see. So we'll go to the next slide. We know that unmet physical needs can cause behaviors, and top of the list is fatigue and hunger and thirst. And I think we've all experienced being hangry before. And so that's like it should be a no-brainer, but sometimes it's easily overlooked. So is the person tired or hungry or thirsty? Those would be hopefully easy things to remedy. They need to use the bathroom. So, you know, asking the person if they need to use the restroom, or maybe they've forgotten, or they're not sure where the restroom is. Also, discomfort or pain. Some common sources might be joint pain or constipation or skin rubbing against objects. So checking those out. Brain changes, you know, through the course of the disease, there's different changes in the brain, and that may lead to loss of self-control, or the person may have some hallucinations or delusions. Adverse side effects or interactions of medications. And so even though we're not really addressing pharmacological interventions, for sure the doctor and pharmacist knowing the different medications that the person is on and monitoring those, and any side effects that the person may be experiencing is super important. And then impaired vision or hearing, whether that was already occurring or as the person ages, that can lead to misinterpretation. So definitely want to think about any unmet physical needs as causes of behaviors. And we'll go to the next slide. Environmental causes for behaviors. This is something that we also always want to take into consideration. Sometimes there's some really simple adjustments and modifications that can be made that can eliminate a behavioral issue. So we kind of talked before about sensory overload, but you know, a loud, chaotic, noisy environment can definitely be too much for people, a lot of people anyway, but especially with dementia. A cluttered environment. So physically, just whether simplifying the environment can make a big change. Sensory deprivation. So if the individual has too little to do or see or touch, that can lead to other replacement behaviors that maybe might not be as beneficial. So giving them something to do and touch and see can be very helpful. Having changes in schedule or routine. Most of us are creatures of habit, and people with dementia are no different. So knowing what's going to happen can be very reassuring. And when there's a big change or something that they're not expecting, that could cause a behavioral challenge. As well as unfamiliar places, you know, maybe a new day program, or having moved to a new residence, or visiting somewhere new and unfamiliar. Another thing to consider, sudden movements and startling noises. Again, just kind of feeling comfortable in our place, and when there's a sudden startling thing that happens, that can definitely cause a behavior change, or maybe someone lashing out or being uncomfortable in some way. Feeling lost or overwhelmed in large spaces, and lighting, the physical light in the place, whether they can see things clearly and navigate their environment, or sometimes shadows or reflections can be a consideration. So paying attention to the lighting of the environment is very important. All right, and we'll go to the next slide. And some other causes of behaviors. We want to pay attention to if the individual feels lost or insecure or forgotten, if their caregiver is not visible. Sometimes just the reassurance of being able to visually see a staff member or a caregiver can reduce behaviors. When someone's given instructions that are unclear or too complicated, that could cause some frustration. Possibly the person feels patronized if they're offered an activity that feels too childlike. So that could be a cause of behavior. Needing reassurance, and we might see, again, repetitive questioning. Lack of social support can also be a cause of behavior. And I believe there's another column of answers there. Yeah, thank you. Changes in routine, again, we like to know what's expected and not be surprised. Having staff who don't understand dementia, or individuals interacting with them who don't understand dementia, can be a cause of behaviors, or who don't tolerate those changes being brought about by dementia and accommodate the person's needs. So having well-educated and informed people in their lives can eliminate a lot of behaviors, because they'll understand and tolerate and accommodate the needs of the person with dementia. So these are all helpful causes to consider. And I'm going to pass it back over to Lindy for some intervention discussion.
Great, thank you, Jennifer. So we can go ahead and move to the next slide. And so I'm gonna be discussing a few kind of, tools you might be able to use that might be a first step in reducing some behavioral symptoms. And then Marty is going to get into some more concrete tools that have some, methods and things like that. But, to start, you really want to become, a detective and start asking some questions when some of these behaviors start to occur, and go down the line of the who, what, when, where, and why. And then maybe has anything recently changed, in Jennifer's case study, she mentioned about Tom, that his mother had passed away, and you want to look for things that might be causing some of these behaviors. And then I think we're going to beat you over the head with the behavior is communication thing today. So remembering that as well. So I'll give, an example of, quite a few of my clients that I work with, say that, oh, well, my loved one, keeps telling me they want to go home. And the caregiver might sometimes take them very literally and will say, well, I tell him he's been living in this house for 40 years and I don't know what he's talking about. This is his home. And sometimes they'll even drive them to maybe their childhood home, and they'll say, that still didn't work. And I think this is a great example of that behavior is communication. And you want to look at that person might be expressing some anxiety, some loneliness, some uncertainty, and start looking at, is behavior, or behavior is communication. And then also looking at, and you can advance, there's one more segment to this slide, but also looking at the way that you're communicating back to the person who might be saying that phrase, I want to go home. It may not be helpful to say, well, you are home, and to really drill, come back with some sort of response that isn't going to be helpful. So that communication is going to either help or maybe hinder, how that person is expressing their anxiety. And we can move to the next slide. So the next step that you want to do is you want to go ahead and identify and be very specific on defining the behavior. So you want to kind of maybe place it in a category, or maybe you have a category that's all on its own that is very specific or unique to your loved one. So you want to look at, is it maybe attention seeking if they're feeling, lonely, or could it be like a verbal outburst or some sort of aggression during maybe a certain care, maybe it's during toileting, or define exactly and very specifically what the behavior is, to then be able to identify what tool you might want to use to reduce that behavior. And we can move to the next slide. And there's one more segment to this slide. Go ahead and advance that. And maybe one more, I'm sorry. So then you want to go ahead and categorize the target symptoms. So this will be helpful in in reducing the behavior when you know exactly what category it's in. You know, I know Jennifer went over some common dementia-related behaviors, that it could be, you know, a delusion or hallucination, and maybe you want to talk to, you know, the doctor about medications, or maybe it's aggression and some loss of impulse control. But you want to kind of categorize and see where the behavior fits and in what category, and then you can continue to look for tools that will fit your needs. And we can move to the next slide. So there are actually quite a few slides. The next few slides are going to be about identifying reversible causes. And this might not have been something that you have thought about before. It's like, okay, you know, what could be reversible before I start getting into maybe looking at medications and things like that. So you might want to look at, I know Jennifer mentioned some, you know, medical concerns. You know, you might want to look at, you know, has the person been tested or treated for, you know, UTI? Could that be causing some, you know, increased, you know, behaviors or agitation from a UTI? Could it be a new medication that has some, you know, different side effects? And then, you know, we talked about those environmental triggers can be, you know, if those are addressed, that could be a huge reversible cause of the behavior. If you just, you know, change the lighting or change the environment that the person's in. And then looking at maybe if there's another untreated illness that's maybe a mental illness that's been undiagnosed or not being treated properly. And then again, back to caregivers, we always, you know, want to encourage some, you know, dementia education, because it really can be so helpful when caregivers have a better understanding. Then they can truly best communicate and understand these behaviors and not increase them, but they can start to address them when they start to understand the disease and the way that it progresses. And I know Jennifer too mentioned some unrealistic expectations, but make sure that you are not expecting too much or maybe even too little of the individual, and make sure you're meeting their needs as well. And we can move to the next slide. And just more, you know, identifying more reversible causes. So you want to look at the root cause and kind of continue to categorize that as well. So, you know, you really want to look at another thing with this is that, you know, is this behavior really a problem, and who is it causing a problem for? You know, is it something as simple as that, you know, the individual's roll, you know, I think this is a great example, you know, unrolling all the toilet paper, or, you know, maybe, you know, something like that maybe it's not really a problem, and that it can be, you know, just some dementia education for caregivers as well. So we can move to the next slide. And just make sure you're addressing, you know, the unmet needs. So I know Marty's going to get into some activity, a slide on activity planning, but I think it's so imperative that individuals who have memory loss, they're still given an opportunity to do something each and every day that is meaningful and has purpose to them. So, you know, a lot of the times I get, you know, kind of sad when I talk to caregivers and I try to help them along through this, but that they say, you know, they used to play bingo or they used to play this card game, but they can't play it anymore. You know, they can't follow the rules or whatever the case is. But in reality, you know, if that's something that still can be enjoyable and meaningful to the person, the rules can go out the window and you can make your own game up, and it can still be a meaningful activity for individuals, just to kind of keep that in mind. And there may or may not, I think there's another portion of this slide as well. And then, that's okay. Okay, and then just again with the dementia education, just, you know, reaching out to community resources or joining, you know, programs like today's behavioral intervention program is a really great way to be able to better understand individuals, and you can help reduce their behavioral symptoms just by being a better educated professional or caregiver. Now we can go to the next slide. Okay. So we're back to the who, what, when, where, and why. So this is where you want to kind of become the detective or a behavior analyst. And when that, the individual has that, is expressing that behavior or having those behaviors, then you can even keep, a behavior log where you can write these things down. So, who was involved. So, what family members were around when the behavior occurs, and then back to defining the behavior, be very specific into what the behavior is. And then looking at time, that can be really important, especially if you're looking at something like, bathing, or if you're having issues during, dinner time or lunchtime. What time of day is it? And follow these kind of sets of rules. You also might consider asking, maybe if you're a professional working with a family, what are the people that know that person best think is the cause of the problem? They might be able to give you a really great insight as to what they think is the cause of what's happening, and maybe have some ideas how that can be addressed. And then you can kind of start looking at some standardized behavioral approaches as well. And we can move to the next slide. Okay. And we can just advance the rest of this slide. An example of this, so what we like to, another maybe simple strategy you could try is to validate, join, and then I think we want to probably use the word redirect rather than distract, but distract the individual. So I'll give a quick example of that. Maybe an individual, we'll use the name George. He's looking for his wallet, and he cannot seem to find his wallet anywhere, and it's maybe been an hour, but the thing is that George actually hasn't had possession of his wallet in over a year. And, as a caregiver, you really, it's suggested to join the reality, and George really believes that he needs to find his wallet, and that's, his reality, that you go ahead and join him and validate him and let him know that, you know how frustrating it is to lose things, and you'll help him find it. And then maybe in the process, you could, pick up a photo book or an old photo album and maybe distract George and try to reminisce with George about, some of the photos and things like that. So that's another, strategy that you can use to try to alleviate some of the stress, but also being on the same side of that individual can be so helpful, and let them know that you're with them and you're on their side. And we can move on to the next slide. So back to activity planning, and again, Marty's going to go into more detail, but, really tap into those, previous interests and occupations. And another great tip is to have some of those, activities you might plan to be really repetitive. They can, gain some confidence of getting really good. We do this a lot. I work at a day center, and having participants help us with maybe a project, or maybe, working on, some thank you cards or something like that, that they can really use some repetitive motion and they can successfully complete a project can be a really great idea. And then, communication, make sure you're slowing down, offering simple or very few choices or one at a time. And then another tip might be to help them find the words. If they're struggling to look for, to find a word, it's okay to help them find the word, and do anything to kind of decrease that stress can be helpful to someone who has some cognitive impairment. And then just a few more tips on environment that Jennifer kind of touched on about removing clutter and establishing routines and things like that can be other great interventions. And we'll go to the next slide. And more about caregiver support, so practicing self-care. I know we're going to be talking about some resources as well as programs for caregivers, but to make sure that caregivers are supported and have, some coping mechanisms in place to help them support them on this journey that can be really, really difficult. So we'll go to the next slide. And Marty?
Thanks, Lindy. So as you said, the focus of this presentation is on non-pharmacological interventions, but that said, we did want to say a few words about some of the dementia medications, antidepressants, antipsychotics, and their use, including pharmacogenomics, which is a newer field of study that combines pharmacology and the person's genetics. and to help come up with the right drug, the right dose, the right frequency, etc. So a newer field that we looked at. So again, we want to employ pharmacological interventions only after all of the psychosocial interventions that we've been discussing have been tried. And when we do employ the pharmacological interventions, such as the antidepressants, the antipsychotics, particularly the antipsychotics, we're looking at short periods of time with the lowest dose possible and regularly monitoring the effects of those antipsychotics. So really a combination of psychosocial and pharmacological interventions can be very helpful, and it can really shorten the time that we need to use those antipsychotics. So I just wanted to mention in terms of side effects of those dementia medications, we want, and those are Aricept, Exelon, Razodine, and Namenda. Those are the four tried and true dementia medications that we have out on the market. The side effects of those are going to be GI. They're going to be gastrointestinal. So a lot of folks can't tolerate these medications because they lose weight. Perhaps their weight's down already, and they lose more weight because they're anorexic, or they have food aversions from them. Diarrhea is another common side effect with these medications, along with vivid dreams and vertigo. So, and then the side effects of the antipsychotics are, too much sedation, constipation. So, there obviously are side effects to any kind of medication that we use. And individuals with dementia already have enough going on and enough to deal with that we don't want to have to add other adverse side effects. So limited use of these medications outside of the dementia medications. Many people take Aricept long-term and Exelon, Razodine, and Namenda. So just a few words about the pharmacological interventions. We'll go to the next slide and really start to look at some of these behavioral intervention tools. Now, we'll look at several, and they have a lot in common. The tools vary a little bit, but they really have these things in common that you see. They all look at what is the behavior, what are some of the possible causes, what can we do about it, what action plan are we going to put in place, and then really important is evaluate it. Did what we do work? Is it going to have long-term, short-term, do we have to go back and try something else? So the first tool that we'll look at is DICE. And this, you can go to the next slide. So this is just one of the tools where you, the D is you describe and define the behavior. You investigate it. Are there reversible causes that we've already talked about? Is everyone safe? That's where we want to start. The C is to create a treatment plan, starting off with non-pharmacological interventions and adding pharmacological interventions only if absolutely necessary. And then again, the all-important step of evaluating. So I think of a woman that I worked with, lived in her home, grew up in the home that she, lived in the home that she grew up in. So she lived in this home, she was in her 80s. For about 70 years, she crossed the busy rural highway to get the mail. She did that for 70 years. That was part of her daily routine. So fast forward, now this woman has dementia. It's not safe for her to go out and get the mail like she did her whole lifetime. And this was a huge problem for the family, keeping her safe. This family pulled out all the stops. I give them so much credit. All the safety, they were at Lowe's and they were at Menards and they were at Radio Shack, getting all of the home interventions that were possible to keep this woman safe. So it was a problem. She was not safe. We didn't have to employ pharmacological interventions for her, but it did come to the point where there were other situations that arose, and it was just not safe for her to remain in that home. But employing a tool like this really helped that family put some tactics into place to keep her in her own home, again, that she lived in her entire life for as long as possible. We'll look at the idea strategy next, where we look at, we can go to the next slide, where we look at the ID as identifying the behavior. Again, what's going on? Who's the behavior difficult for? Is it difficult for the individual, or is it difficult for the caregiver, or both? What's happening around the person? We'll come back to this in a little bit. I'm going to move on to the next slide. So we talked about the ID in idea. The A is for adjusting. You can go ahead to the next one. Or go back, yeah, okay, adjusting what can be done. So that's our A. Sorry if you want to go back, thank you. Stay right there, thank you. So we're going to adjust what can be done. We're going to address what's actual causing the behavior, keeping the tasks and activities simple, keeping the home as calm as possible, the way that we communicate with individuals, not arguing, not correcting the person. In this case, telling that individual that she couldn't go out to get the mail was not a helpful conversation with her. It almost, had the reverse effect, where she kind of really, at that point, wanted to prove everyone wrong and remind them that she was able to do that activity. We'll go to the next slide. And the E in idea is to E is to explore what is going on in that situation. There we go. So understand the cause of the behavior. Again, is it related to health? Is there a UTI going on? Is the person sick, constipated? Is it the environment that's too noisy? The task that's too difficult or too easy? Is it the communication, the words that we're using? And then we want to understand the meaning of the behavior. Does that person feel confused or nervous? Again, is that person bored? I think boredom is the root cause of a lot of behaviors. We're going to talk about a case coming up where the woman is constantly cleaning out the closets. And I think of my own grandmother who raised 11 children. I don't think her hands were ever idle, and her feet were probably never idle. So now to ask this person to sit in a chair most of the day is just counterintuitive to how they live their whole life. We can go to the next slide, please. And I think we need a backup one. Okay, adjusting to what can be done. Right there. Adjusting to what can be done. I think maybe I already covered this one, and we'll go on to the next one. And then distracting or redirecting. Again, we've covered a lot of these things. Along with adjusting our expectations, the A can also stand for accepting the behavior. Some behaviors we just may need to accept rather than to try to change it. If there's no safety concerns and it's not bothering the person, we as caregivers might just have to find a way to live with it. And that can be tough. And this is where those resources for caregivers are so important. If there's a behavior that is going on in my home as the caregiver that I really can't change, then it's important for me as that caregiver to get a break. And that can come through a home health care person coming into my home. It can be a friend coming over to give me a break. It can be the use of an adult day center. A lot of different resources that we'll talk about at the end. Okay, and one last tool that we have is the ABC. This comes from Linda Terry at the University of Washington. And with this, the ABC method is really helpful in looking at the A as an activator. So we look at what happened just before B. What was the behavior, or what is the behavior going on? Who's present? When was it happening? Where was it happening? Again, these tools are all similar in really breaking down what's going on and developing a plan for what we're doing. So there was an individual, again, that we worked with who loved to drive but had to give up driving. Had a home health aide come into the home. She sat her car keys down on the counter. Well, the individual with dementia saw the car keys, picked them up, and drove her car away. So the ABC approach to this is, you know, we can look at what happened just before the person drove off. Well, the car keys were in plain sight, and it was a trigger, and it was probably exciting that, oh, there's my keys, there's the car, I can drive again. So, you know, we had to get the police involved and so forth. It all resolved okay, thank goodness. But we can really use this approach to think about what can we do different in these situations. And this one is pretty easy. You know, just the car keys stay in the purse that's put into a closet or wherever. You know, the keys are kept out of sight. Some behaviors are a little bit harder when we use these different concepts. But I think the approach, the important part here is to pick a tool that you're comfortable with and use these when you're encountering a difficult situation, so that that plan can be developed and it can be evaluated and adjusted as needed. Okay, so I know we are running kind of out of time here, so I'm just going to read this case study really quickly. Helen is 83 years old and she lives with her daughter, and her daughter moved from out of state to take care of her mother. The daughter's come to you because she's really concerned about her mom's constant moving around the house and rummaging through her belongings. She empties out her closets and her drawers, and then she folds and refolds the clothes. She gets on a step stool to empty out the kitchen cupboards. She washes the shelves and then puts all the items back. And additional information is that Helen was diagnosed with an unnamed dementia about 7 years ago. The daughter moved home after receiving reports that her mom was leaving the house at nighttime, knocking on neighbors' doors, and she's underweight from poor nutrition. And the doctor said that the mother's health was suffering from not taking her medications appropriately. So if we think about some of those tools that we just discussed, we can really look at, are there real behaviors here? Who are they bothering? Are there some things that we can kind of let go? Maybe, you know, refolding the clothes and cleaning out the cupboards. Maybe that's got to be. Now, the fact that she's getting up on a step stool does present a safety issue, obviously. But there are other behaviors here, walking out at nighttime and knocking on the neighbors' doors. Obviously, there's a safety concern here. So I think we need to sort out what are true behaviors, what are not. How are we going to intervene? How are we going to use some of these tools to look at what happened just before? Some of the environmental considerations. Is this woman bored? Is this woman looking for something? Did she work? Look at her life history. Did she work in a clothing store most of her life? Is that what she's relying on in her long-term memories? Is the fact that she was always organizing clothes in her work? So we haven't mentioned person-centered care a lot yet in this presentation, but that's another huge process in identifying behaviors, is really looking at that person's history, their work history, their family history, their likes, their dislikes, and factoring all that into the equation. So I am going to turn it over to Jennifer, who is going to talk a little bit about maximizing those abilities.
Great. Thank you, Marty. You know, obviously, when we're talking about dementia behavioral interventions, we know already that the person has some deficits because of the virtue of having this diagnosis. But sometimes it helps us to address challenging behaviors and the behavioral issues when we maximize the abilities. So switching gears to focus on the strengths that the person does have. And some of the ideas around that are the social skills and the motor memory, tapping into the person's spirituality, past talents, hobbies, interests. Like Lindy said, if they have a game that they used to love to play, who cares about the rules? If they can't do, crochet correctly, but it gives them some enjoyment and some familiarity, that can be very reassuring. So tapping in, identifying, and focusing on those remaining strengths that the person does have can really help when we're talking about behaviors and just kind of quality of life. We also want to make sure that we're identifying and treating any coexisting conditions that may worsen the dementia symptoms or could lead to poor outcomes. So just some of those could include diabetes or high blood pressure or sleep issues. Some other common coexisting conditions are chronic kidney disease, congestive heart failure, COPD, stroke, and cancer. We also see issues with sleep disturbance and incontinence, wandering and aggressive behavior, and those can all be predictors of long-term care placement. And so when we think about trying to help the person age in place as long as possible, as well as supporting caregivers, having these conditions under control and being treated is really important. We also, I wanted to touch base on some common medical conditions. Oh, sorry, if you can go back, I'm not quite done with that slide, but some common medical conditions in aging adults with Down syndrome. When we talk about the IDD community, we see things, or we should pay attention to any indications that the person may be experiencing vision loss or impairment, hearing loss or impairment, things like hypothyroidism, which can contribute to symptoms of fatigue and mental sluggishness. So that is important to identify and treat, even if it's coexisting with dementia. Sleep apnea, obstructive sleep apnea, can lead to poor quality and non-restorative sleep. So that could lead to people feeling sleep deprived, even if they appeared to have a full night's sleep. Osteoarthritis can cause pain and stiffness, which could make tasks more difficult to perform and contribute to irritability. Other issues with cervical spine disease, osteoporosis can lead to pain and impaired mobility, as well as celiac disease, which is an autoimmune disease causing inability to digest wheat and gluten, and can lead to stomach distress, vitamin deficiencies, and weight loss and overall irritability. So paying attention to these coexisting conditions and differentiating those between whether that's part of the dementia or something separate is really important. But regardless of what's going on, offering strategies to reduce those behavioral symptoms is very important. And so communication and then wellness and social engagement, as well as our paying and honoring the person's routine preferences, is very important. So now we can go on to the next slide, please. So activity planning. Remember that finding activities that are of interest and enjoyment for the individual. So that is, person-centered and strengths-focused. It's more about the process than the product. We're not looking for perfection here, but we're looking for meaningful, engaging activities. Like Marty mentioned with her grandmother, living such a busy life, raising so many children, the past leisure and work activities and habits of the person can really give us some great ideas of what they may enjoy now and what they're going to tolerate and what they're going to want to spend their days doing. So ensuring the task is not too hard, but not too easy. Reminiscence activities are very popular and engaging for individuals. So that could be listening to music that they've enjoyed in years past. It could be photo albums, other things that maybe they grew up with that could be discussed and shared. simulating household activities. So we talked about the lady that wanted to, kind of organize the cupboards over and over. And again, that might be, it could come across as a little bit annoying or bothersome for the caregiver, but if it's serving a purpose, it might be something that we just accept and as part of helping the person have something active to do. Musical activities, again, playing preferred music, watching musicals, dancing, watching dancing. Nature activities are another popular activity that could be bird watching or spending time in a garden. Simple crafts and hobbies, again, possibly tying into previous hobbies that they were able to do, and they could do maybe in a more simplified version. Outings into the community and faith-based activities. A person with dementia may still be very interested in faith-based activities, participating in something with their congregation perhaps. So these are all ideas related to activity planning. Then we can go to the next slide. And communication. So we always want to treat the person with dignity and respect. We always want to acknowledge their presence, not talk as if they're not in the room or talk about them in front of them. Body language and tone of voice is so important for all of us, and definitely for individuals with dementia. Our nonverbals and how we hold our body, our position, is also important. We don't want to argue or try to reason with someone. We want to join with them, like Lindy talked about earlier with George and his missing wallet. We're going to speak slowly and clearly, and approach the person from the front. So we're not going to try and talk from behind them or around the corner. We're going to talk in front of them so they can see who's talking to them. Positioning ourselves at eye level with them is helpful. So if they're seated and we're standing over, we can crouch down or pull up a chair next to them. That can be a helpful way to just clarify communication. We want to avoid questioning the person, which can make them feel possibly frustrated, or and we want to use repetition when needed. And if you could click the other column of, thank you. So a couple of these bullet points refer to what I call I've been told is the rule of 7. So allowing time in between the sentences for the person with dementia to process. Sometimes we need to allow up to 7 seconds or longer when we're telling or asking a question for the person to process and reply. Also using statements that contain 7 or fewer words. So we want to use concise statements that are more concrete, so the individual doesn't have to try and figure out who we're talking about. We're talking about he or she. We'll use names, using visual cues such as pointing. So maybe they don't recognize the word that we're saying, but we gesture over to what it is that we're talking about. Eliminating the words no and but can be helpful, using statements that validate the individual and redirect them. For example, I know you want to go home. I like being at home too. So we didn't say, I know you like to be at home, but you can't, but it's not time. We're saying, I know, we're validating their feelings. I like cooking when I'm at home. I was thinking you and I could work on setting the table together before we have lunch. So we are redirecting and we're not having to tell them no. So next slide, please. And some final ideas for simplifying the environment. Kind of alluded to some of these, but creating small, intimate spaces can keep from a big, loud, noisy environment where it's maybe harder to navigate. Providing regular routines that the person kind of knows what to expect. Maintaining consistent staffing. So again, knowing who's going to be working with you each day or caring for you. Choosing that appropriate lighting, evaluating the environment. Is this, are there shadows? Is it easy for the person to get around and see openings to doors and that kind of thing? Reducing distractions, whether that's, noise or otherwise, minimizing the clutter, and just kind of simplifying the environment overall are all successful ways that we can help support someone in their environment. So pass this back to Lindy, I believe, for our next slide.
Thanks, Jennifer. And we can go on to the next slide. So I'm going to move on and talk about some caregiver support materials, and I'm kind of going to zip through this, but we just want to stress the importance of interventions that are helpful for individuals who are living with dementia as well as their caregivers. So making sure that, as Marty mentioned earlier, that caregivers are seeking out respite care, whether that be involving family members or friends in the care to give them a break, or in-home care, or some sort of adult day service. And there's also a program that Lori Sharp is going to talk about at the end of today's presentation, the Benjamin Rose Institute on Aging Care Consultation Program, that can be helpful for caregivers, and also for professionals to encourage caregivers to accept help and assist them in any way you can to maybe make a referral for them, help them get the ball rolling to set up some supportive services for families can be very helpful. And we can move on to the next slide. Just to stress the importance of, like I said, the caregiver support, which I'll get to, just to be aware of the signs of burnout. If you're a caregiver, make sure you're aware of your own limitation and that you have to take care of yourself. I know if you're a caregiver out there, I probably sound like a broken record. You have to take care of yourself before you can, take care of your loved one, but it is the truth. So knowing those signs of burnout, and watching out for other signs of depression, or neglect or abuse as well, and seeking out those supportive services. And we'll move on to the next slide. So there are a few online resources, and you will get a copy of this PowerPoint. You can refer back to these. So the Alzheimer's Los Angeles, they have quite a few. We can go to the next slide. That shows these. These are really great one-page tip sheets that can be shared with, professional families, and they're really wonderful because they give you some really great tips, and they're really nice because they're one-pagers. And you can move to the next slide. And this is kind of a list, but they're all on their website. They're all online. They're really great, easy to print and share with others. And we'll move on to the next slide. So Ohio Council for Cognitive Health, so that's where Marty Williman is from. They have some really wonderful tip sheets as well that give a little bit more detail, but have really great topics, a few on communication, that really stress some of the things that we've been talking about today that can be really wonderful for families and professionals to increase this dementia education to help individuals as well. So we'll go to the next slide. And go ahead and advance. We can see the cover of the book. So this is my go-to. So the next couple slides are just a few books that I guess I would maybe recommend looking into if you're looking for a really great book. So like I said, this is kind of my go-to book when helping families address these challenging behaviors, because they have, the chapters on bathing or communication or agitation and anger, and some really great tips. And this one's by Beth Spencer and Lori White. And we'll go to the next slide. And the second one is the Alzheimer's Caregiver Playbook, which is written by Coach Royals, who cared for his wife, and he was a football coach. So if you know any, male caregivers, I think this is a really excellent book for anyone, but specifically maybe, male caregivers need to be represented as well. So it's a wonderful guidebook as well. And then the next slide. And another great book, in the last book I'm going to reference, but this one's the Alzheimer's Action Plan, which is kind of an A through Z guidebook on Alzheimer's disease. Another really wonderful book that you might recommend or consider reading. And then we'll go to the next slide. So the next three slides, and like I said, you'll get this PowerPoint, but this is also a resource from Act on Alzheimer's, which is through the state of Minnesota. So they have some really great, I know it's hard to see on here, but you can zoom in when you view the tables. They have tables online that show some target behaviors, and then it shows specific non-pharmacological strategies that you might consider trying. So these are a little bit more in-depth, but really give you, some additional resources that you can look at. And we'll just go ahead and flip through these next two slides, because these are all tables through the Act on Alzheimer's. I highly suggest you take a look at them when you can actually see them. And I think that's all that I have. We'll go ahead and zoom through the references. And I think we might have some time for question and answers, but thank you so much.
Wonderful. Thank you so much to our audience and our presenters for our audience for being engaged and our presenters for their presentation. We do have time for just a couple questions. What strategies would you recommend for individuals who get upset when attempting to bathe them?
Marty, do you want to?
Sure, and I had those strategies written down, and I just, didn't think we had time to go into them. But I think some of the things that we need to look at first is, what is the bathing routine that person is remembering? Did they always take a bath at night? And now here it is 7 o'clock in the morning, and we're attempting to have that person take a shower. So trying to mimic the routine that person always maintained their life. Again, sometimes it's not possible, but I think we can look at some innovative ways to accomplish getting that bath done. And Lindy referenced that book, Dealing with Challenging Behaviors, and that has 2 pages on bathing. Are the towels warm? Is the bathroom warm enough? Is the person refusing because they have difficulty getting undressed? Is it the person that's helping them with the bath? Do they seem unfamiliar to that person? It might be their daughter, but that daughter might not seem familiar to them anymore. And sometimes bringing in a non-family caregiver to help with that bathing process can really help. Those are the things that come to mind. Lindy and Jennifer, you might have a couple more to add there.
Oh, great job. One that just came to mind is try to find a time that isn't rushed. So there's not the pressure to try and get that done, and absolutely honoring the person's preferences, whether it's bathing over showering, day, morning, or night, can be very helpful.
Thank you. An attendee shared that as a family caregiver, their father's provider has never discussed with them about their father's functional skills or needs. Do you have any suggestions for what they could do?
Do you mind reading that one more time?
Yeah, no worries. An attendee who is a family caregiver shared their father's provider has not discussed with them their father's functional skills or needs. Do you have any suggestions for what this attendee could do?
Well, depending on what the setting is, if the father's in a long-term care community or if the father's at home, I guess I think there's a lot of assessment that we can do as non-providers, as family members, to really look at that functional status. We don't always have to rely on that professional to give us that designation. So I guess just observing as much as possible. Now, if it's a long distance caregiving situation, that might be difficult, but getting some of that information from the direct care staff, if there's a home health aide in that home, or if that person lives in long-term care, getting that information from the nursing supervisor, the nursing staff, just starting from that point. Lindy, Jennifer, do you have anything to add?
No. Yeah, I would just, want to get an updated baseline, I guess, or there's some of these assessments that Lindy went over earlier that might give you some ideas of what to ask as far as where he is on, what can he do right now if you're maybe at a distance and not seeing him regularly yourself.
I think to add to that, Jennifer, that brings up a really great point, is that, oftentimes, sometimes what I do as a care consultant is work with families on how to communicate with doctors. And I can't think of one off the top of my head, but maybe doing some research online as far as some tips to help better communicate with your doctor, or that could be helpful, or questions asked, or how to be prepared for your next doctor's appointment. Sometimes, I think you go to a doctor's appointment and then people say, well, I forgot to ask my doctor this, and just preparing for a doctor's appointment can be a helpful tip.
Good point.
Thank you. I think this is going to be our last question, but do you have any advice for providers around involving family caregivers who know their loved one best?
I would just say, providing opportunities through family meetings, if possible, that involve the different healthcare providers. Now that we have more Zoom technology, I think that's an easy way to pull in family caregivers. Just trying to make the family caregivers aware of how the disease is progressing and some of the really important areas that need to be addressed. Jennifer and Lindy?
I think to add to that is to, maybe a lot of caregivers, usually there's a main caregiver and maybe there's some other siblings that are involved, but maybe talking to the main caregiver about identifying what are the other strengths of the siblings, because I think that a lot of times, people have different strengths, or maybe they're able to do some things but not others, but just maybe, working through that list of, okay, what can, sibling 1, 2, 3 do? That you can play off of what they're capable of and what their strengths are, could be a place to start.
I like that a lot. And I think, just making the invitation and sharing, sometimes it can feel intimidating if our loved one has a medical condition and maybe we're not medically trained, but we all have something that we can do too. And so being invited into the conversation and feeling that we have a part to play can be helpful.
And that's just a great segue into the care consultation program that Lori's going to talk about, because that is a large part of it is involving other family members who might not be as active, or friends or other folks in the community.
Yeah, thank you, Marty. Thank you again to our presenters and to our audience for their questions. Before we conclude today's webinar, Laurie Scharf, BRI Care Consultation Master Trainer and Care Consultant, is going to briefly talk about BRI Care Consultation, a care coaching program available for families impacted by dementia in Cuyahoga, Athens, and Washington counties in Ohio through the new Administration for Community Living project. Go ahead, Lori.
Thank you so much. We received a lot of great information, and the case studies helped give us a picture of what's going on. It was all very insightful, the information that we received. I think it's important to remember that dementia is not a one-size-fits-all type of disease, and that it is important to treat the person, not the diagnosis, when you're working with them. So BRI Care Consultation is a program that looks at 35 different assessments. So when you're asking the question about that the doctor didn't give you the functional abilities. So we have this, it's not a clinical, but we have 35 different categories that we're talking with you and asking what's working, what's not. And when we look at care consultation, as you can see, it's telephone and email based. The caregivers don't have time to be leaving their loved ones, finding somebody to stay with them, going to an appointment. This is an easy program that you can correspond through the telephone or email, that we assist and support adults with that are at risk for developing dementia, including those with intellectual and developmental disabilities, and their families and caregivers and other supports. So I'm thinking of the last question is, how does the provider get the family involved? My first thought was create a life story so that the staff knows who this person is and what was important to them, so that they're able to better communicate with them. So the next slide, please. So when you sign up for BRI Care Consultation, you have your own personal care consultant, the same one that walks with you on this journey. The care consultant helps you find and connect to health community service services. We prioritize your concerns. We help you communicate with your loved ones. You know, so many times the dynamics with the family, there are difficult situations, and a disease does not necessarily bring everybody together. We stay in touch with you on a regular basis, and we create this action plan that helps you adjust what's going on, that changes as your need changes. And we assist with maybe getting other family and friends involved. If the care consultant is doing all the work, we know that the burnout potential is great. We're there as an emotional support. One of the pieces, you know, Lindy was providing some great resources, and in an era of social media where there's so much on the internet, how do you find what is a good resource and what is just some of that voodoo magic that's out there? And so your care consultant helps you kind of decipher through and find those pieces that are really important for you and that help you as a caregiver, as well as help you support your loved one who has the diagnosis. Next slide, please. So as a result of this, we are working through a grant through the administration for community living, and we are looking at the needs of folks in Athens County and in Washington County, looking at the needs of the rural folks, as well as those in Cuyahoga. Our program is designed to support those who have intellectual and developmental disabilities, and also your plain old garden variety caregiver who is supporting their loved one in the process of what's going on. We're delivering it in Cuyahoga County through Benjamin Rose, the We Care program. So what we would like you to do is, here is all the contact information. If nothing else, use that Benjamin Rose number to talk to us and say, you know, these are some issues that I'm having. Who is the best person that I can talk to? How do I get connected with a care consultant who is going to not walk in front of me and not walk behind me, but walk beside me on this caregiving journey? So thank you very much.
We want to thank you again for joining us for behavioral interventions when caring for someone with dementia. A recording of today's presentation will be available at www.benrose.org on the event registration page and in our resource library. We will be offering more webinars like this for community organizations and families impacted by dementia each project quarter. To stay up to date on dates and topics for these upcoming webinars, please visit our website. Later today, you will be receiving an email with a link to a post-session questionnaire. It is also posted in the chat. We ask you complete this post-session questionnaire within 1 week following today's session. Your response will help us improve dementia education programs and help us think about future services and supports for individuals with dementia and those who care for them in your community. Thank you again for joining us, and have a lovely rest of your day.